Dr. Mikhael was kind enough to come out here at the beginning of the week to help with the teaching for our Chinese guests. And so it's especially fantastic that he went home to do a clinic at 2:30 in the afternoon, and now he's come back again today. So very, very pleased to welcome Joe to talk about the treatment for patients who may not be eligible for transplant. So please welcome Dr. Mikhael.
Thanks, Brian. Thank you. Thanks, Brian. It's always a pleasure to be here. I very much enjoy spending time at the IMF. I actually just last month, as you know, I had the privilege of doing one of the patient IMF meetings in Sao Paulo, Brazil, with about 600 patients. We packed the house, and it's just a privilege for me, and I'm not saying it just to get brownie points. I give talks all year long. I know, like Dr. Vescio and Dr. Dury, probably over 100 talks a year, but the ones I give to patients are particularly enjoyable to me, because this is why we do what we do, right? It's for you. This is going to be a very serious talk. I do not want to see any smiling or any laughing, consistent with my character and with the way I approach things. This is serious business here. So we're going to talk a little bit about initially treating patients with multiple myeloma, and what I'm going to try to achieve in the next 20 minutes with you is as follows. We'll talk a little bit about when we initiate treatment for myeloma. And we've talked, Brian has already shared with us a little bit about the notion of initiating treatment, but it's such an important point. Myeloma is a very unusual cancer in the cancer world, that there are people who are walking around, maybe even in this room, who have myeloma, but we're not treating them. And it sounds a little counterintuitive, but for myeloma, this is an important phenomenon. There are people who do not necessarily need treatment. They get what I call my favorite treatment, nada, right? Okay, that was a joke. So thank you. All right, thank you for the one person who clapped. So, but nada therapy, as I like to call it, is great therapy because its cost profile is quite good. People tend to be very compliant with it, and there are very few side effects. So, and I don't say that to joke per se about the disease, but there are some people in whom we might just say, let's wait. And we all have patients in our practice who have, I think of several in my practice, even a few I saw this week, who were diagnosed with myeloma over a decade ago and still are on nada therapy. And that's important to note. We'll talk a little bit about risk stratification. That came up with the excellent question regarding how do we risk stratify patients, or how do we stage patients. I mean, frankly, at the end of the day, there's two stages of myeloma: the stage that needs to be treated and the stage that doesn't need to be treated, right, in many respects. But we'll talk a little bit about how that factors in. And then we'll, instead of me just going through every study that's ever been done for patients not eligible for transplant, and turn this talk into Charlie Brown's teacher, wah, 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 and the following, like when you go to our medical meetings, that's basically what happens. The doctors stand up and say, let me go through the 302 slides I've prepared for you today, and the following study demonstrated, and the following study, and after a while, all the curves blend in together in your brain, and you've lost it. I'd rather just think with you about what are the hinge points, what makes me want to start a patient on a Bortezomib-based therapy versus a lenalidomide-based therapy, or maybe even now in some respects carfilzomib and some of these other drugs that we're talking about. And then hopefully, finally appreciate, this is the objective, that's sort of the let's hold hands and sing Kumbaya moment, let's appreciate that really, although Dr. Harousseau will be focusing on patients going to transplant and I'm focusing on patients who don't go to transplant, to be very honest, the difference between those two groups is limited now, and very often people are treated similarly whether they're going to transplant or not, and I'll explain what I mean by that as we go. So even though, as you see here, we still, generally speaking, divide patients into transplant eligible and transplant ineligible, their initial therapy can often be quite similar, and I'm going to be focusing on this first purple box in addition to the other things later. Oh, the other pointer works better? There we go. Oh, everybody? Ooh. Yeah, I got to make sure they stay awake. Okay. Smashing. So previously we really defined myeloma in almost three categories. There was this thing, and there is this thing called MGUS, or monoclonal gammopathy of undetermined significance. It was actually coined at Mayo Clinic by Dr. Bob Kyle, who helped recruit me to Mayo. So I'm very grateful for him. He is an outstanding speaker for those who have heard him speak. He sounds a little bit like Walter Cronkite, right? So when you become a myeloma doctor, you have to be able to pronounce monoclonal gammopathy as Bob does, right? So it's monoclonal gammopathy of undetermined significance, right? So if you can do that, you can apply for the job, right? But the bottom line here is that these are individuals who obviously have an abnormal protein in their blood from a limited number of abnormal plasma cells in the bone marrow, but not enough that we need to treat them. These are the people we treat, if you will, with nada. I tell patients like a little bit of dust in the corner. It's there if you look for it, but if we didn't look for it, frankly, it's not affecting the room, and you'd say that the Sheraton has a nice clean carpet here, and there's no need to get a vacuum cleaner, right? But at the other end of the spectrum, people have true myeloma where they're being affected by the disease, as you've heard already. And then in the middle is this smoldering business. And you've been hearing already that we've been talking about this issue of slim crab. We used to say the only reason why you would treat someone is if they already had damage, or what we call crab, the calcium elevation, renal insufficiency, anemia, and bone disease. Well, we added 3 criteria to this in our International Myeloma Working Group, hosted by the International Myeloma Foundation. And we came up with these 3 to add on to these 4 because, as I described to patients, if I see someone running towards a cliff, do I really have to wait until they're falling down the cliff to know that they're going to be in trouble? No. So these are 3 indicators that someone is getting really close to breaking a bone, or to damaging their kidneys, or to having other problems with their myeloma. On the other hand, if the cliff is 3 miles away and it's a beautiful day and someone's walking really slowly, I might not have to stop them. So we've tried to identify 3 things. If someone has more than 60% plasma cells in their marrow, light chains of what we call involved over uninvolved. As you know, people either have kappa or lambda, light chains elevated, so it's the involved one over the uninvolved one over 100. Or if on the MRI we find more than one abnormal spot, then that indicates that they have active enough myeloma that you should treat them. Don't wait, because if we do wait, they're likely going to come into damage. And if you're going to treat patients, then we say, well, is autologous stem cell transplant part of the plan here? And if the answer is yes, then please stay for Dr. Haruso's talk in a few minutes, and he'll fill you in about how we approach the transplant side. I'm, on the other hand, going to spend the next little bit telling you about the non-transplant side. And again, it's not that we want to deprive people of stem cell transplant, but we've come to appreciate that transplant can be a tough process, and there's some people who would not be eligible for it. Not that we're ageist, but in general, when people get to the age 70 or so, we know that it's going to be more challenging. And I don't want to be prophetic. There's some myeloma doctors who are claiming that transplant is going away. I actually don't believe that. I still think there are a lot of patients who benefit from transplant. But there may be a group of people in whom we're transplanting less in the coming years, because we say we have all these other options. Do we want to go through a process that unfortunately takes you out of work for 3 months, that very often requires a hospitalization, that you can get quite sick with? Thankfully, it's quite rare now for someone to be so sick to die of a transplant. That's not routine, and we're grateful for that. But there's still a lot of challenges going through transplant. So there may be some people in whom we do it less, but transplant will still be, I think, a very valid option, and that's obviously in support of what Dr. Haruso is going to share. But I'd like to think about those individuals who, as I say, generally speaking, are 70-ish or older, and how is it that we approach their initial therapy for their myeloma? Well, as I say, I could go through Charlie Brown's teacher here and just go through all of these studies, one after the other. I don't want you to notice anything on this slide apart from the fact that as we've gone from some of the older studies, brilliant studies, some of these that I know Dr. Haruso participated in France, but as you generally speaking look down this column here, we start to see that as we've gone, we've gotten higher numbers. We've gotten more patients into remission than we had before. We have patients living longer than we had before, and that's a very encouraging phenomenon that we're grateful for. And similarly, we've started to see that survival rates, 3-year overall survival. When I sound like the old man now, when I was a medical student, but when I started my training and became interested in myeloma, I partly became interested in myeloma when I was an internal medicine resident, and I got a phone call from the emergency department that there was this young guy who had been playing hockey. As you probably know, I grew up in Canada. Eh? Any Canadians in the crowd? Dude, not one? Honestly, wow. Susie, I think you need to order some maple syrup for lunchtime, all right? Can you do that? And he was playing hockey, and he had this really bad back pain, and it didn't make sense. And sure enough, this poor young man had a spine riddled with holes because of myeloma at the age of 25. Well, it turns out he was my classmate from high school. And he's still with us, and he's still doing really well. And I'm a little bit older than 25. So, but in those days, it was very unusual for us to think that myeloma patients could live more than 2 or 3 years. And now we're seeing, obviously, a dramatic change in that. We're grateful for it. So one of the key messages that I want to share with you is firstly that MP, or melphalan, which we used for many, many years in myeloma, is really not the standard of care anymore. We can better melphalan by either adding thalidomide or bortezomib, or the V for Velcade. But I'm going to show to you that even now, I would suggest we've gone beyond that. That melphalan is not historically something that we're using up front. Even though we see these what's called ORR, or overall response rates, and complete remission rates, we're seeing really fantastic responses when we add these agents like bortezomib or thalidomide to melphalan and prednisone, but we're starting to come to appreciate that maybe we don't even need the melphalan up front, and we'll talk a little bit about that. So for many reasons, most initial strategies now don't even use melphalan. Well, why is that? Well, I'll give you 4 reasons why. In general, we're not using it. And that's not to say if you've been given melphalan, you've been given the wrong treatment. It's to say that the field is evolving in such a way that we're moving away from initially using melphalan. Novel agents, and this is an interesting phrase, but basically refers to these newer drugs, which sometimes I think of as the big 5. Thalidomide, bortezomib or Velcade, Revlimid or lenalidomide, carfilzomib or Kyprolis, and pomalidomide or Pomalyst. I'm not saying those are the only 5 drugs in myeloma, but those are really, if you will, the backbone key 5 drugs. So when you hear the expression novel agents, we're generally speaking of those 5. We've come to appreciate those novel agents, even by themselves, are definitely superior to melphalan and prednisone, and we can use them without melphalan and prednisone and still get the same outcomes. So we could be potentially saving, if you will, the melphalan for later. We know that when we do add these drugs to melphalan, there can be more what we call short-term toxicity. Melphalan is a bit tougher on your bone marrow. It can drop your blood counts. Thirdly, as we're starting to see survival extended in myeloma, and if there's one thing I want to bring to the myeloma community, it's this. We can't have short-term vision anymore. When I see a patient in my clinic, we talk about the long-term strategy. And I fully appreciate that I don't want to minimize their treatment in the short term, just to sort of keep chipping away at the disease for years. But on the other hand, I want to make sure that I have a long-term plan for them. This is not a sprint anymore. This is like a marathon. And so sometimes I say to patients this way, it's not a game, but I want to play the best card for you, but I want to play the card that lets me play my other cards later. And so thinking sequentially, if I have a sequential approach, I'm probably not going to put melphalan up front if it's going to cause some issues in the short term, and indeed my final comment here, that maybe even in the long term. We know that all myeloma patients are at risk of getting a second cancer, independent of their therapy. That risk is probably in the range of 4 to 5%. When we add certain strategies, we might increase that more to 7 to 8%. Still a low number, but a significant one. And so we're suggesting that melphalan comes a little bit later. But what are the trends now in treating older patients? Well, first of all, that we're using novel agents. As I mentioned, we're using less melphalan. But the other perhaps important point here, it's not just that we're moving away from melphalan initially and we're using these novel agents. We're treating people for a longer period of time. When we used melphalan, we historically used it for 12, maybe 18 months. Because if you get more than 18 months straight of melphalan, it's pretty tough in your bone marrow, and your good blood counts are going to be affected, and it can cause other trouble. But now that we're using drugs that don't have that same kind of potential to damage the bone marrow, or at least less of that potential, we can use them for longer. And some patients do very well when we just keep our hands on top of the pot and keep the lid on top by giving them continuous long-term therapy. Sometimes the word maintenance therapy is used, or long-term or continuous therapy. And as a result, thankfully, we're seeing increased survival. So when you are initially treated, what's the point? Well, you want to get a response, obviously. You want to see the disease go down. Sometimes we really want to see it happen rapidly. If there's a lot of evidence of CRAB and the kidneys are affected. I just brand new diagnosis myeloma patient this week, a 50-year-old woman. She came into the emergency room because she'd been sick. She was in kidney failure, needed dialysis. Her light chains were extremely high. This is someone where we want to get their numbers down pronto, right? We want to move quickly. Sometimes it's maybe not as urgent to get it down quickly and we can take our time. But very often we want to get it down. And it's not just about getting the numbers down. I always talk about the 2 Ds. It's not just the depth of one's response, it's the duration of one's response. We don't want to get too excited about a number dropping and then shooting right back up again. We want to be able to keep it down. And of course, we're there to improve what we call performance status. I like to say all the time, I don't treat myeloma, I treat people, right? And so I had a patient yesterday in clinic say to me, well, there's this happening in my life and that happening in my life, and I guess we'll just have to wait and see. I said, look, I'm not here to just see your M spike go down. I'm here to make sure you can get to your daughter's wedding, right? So let's take every approach that we can to do that. So that's an important point I would suggest that you take home today, in sharing with your discussions with your family and your physician, that it's not just about, woohoo, my M spike went down by 0.5. No, it's I have now the opportunity to do what I want to do and to engage my life more, because it's not about a number, it's about a person. Now, sometimes as we've mentioned before, it does depend on the genetics. You can have 2 myeloma patients sitting next to each other. I'm not sure if this happens at the patient family seminar, like, hey there, come here often, what was your % plasma cells, huh? What did your cytogenetics show, right? Been fishing here for long? So, but you can have 2 patients that in a sense almost look identical. They may have the exact same number of plasma cells, the same level of M spike or light chains, but their disease can be very different based on, as Brian shared, the genetics of those plasma cells. I explained to my patients, plasma cells that have gone cancerous are like bad cops. And sometimes there are cops that are just a little bit bad, and then there's some that are very bad. And that's I'm not trying to insult by any means our police force. We appreciate what they do for us. I'm just using it as an analogy. And so some people can be very sick with the same number of plasma cells as someone else. And that might influence what treatment we give, because we've learned that some cytogenetic features respond better to certain drugs and need more aggressive therapy. Whereas, as Brian mentioned, sometimes when people have, for example, hyperdiploidy or extra copies of certain chromosomes, we know those patients live longer. And maybe we don't have to be as aggressive and give them all the therapies at once. We might be able to approach it more mildly. So most would agree that at least a proteasome inhibitor, so Bortezomib or Carfilzomib, or an immune modulatory drug, thalidomide or lenalidomide, are needed, and sometimes we might put both of those classes of drugs together in certain situations. And then in addition, most people will add a steroid to that to boost the response. And sometimes they might add something called cyclophosphamide that many of you are familiar with. So I'd rather give you this kind of approach than just listing all the different trials. So that means some people will get lenalidomide and dexamethasone, or lenalidomide, cyclophosphamide, dexamethasone. Some will get bortezomib, dexamethasone. Some will get a regimen that we often use at Mayo known as Cy-Bor-D. Sounds like an alien, but cyclophosphamide, bortezomib, and dexamethasone. There's certain contexts where thalidomide is still added, or sometimes we put the 2 biggies together. We give them bortezomib and lenalidomide together in certain contexts with dex. Other new ones that are either emerging or that are still lingering is the carfilzomib-based strategies. So the NCCN has listed the possibility of using carfilzomib frontline. So sometimes it's combined with lenalidomide, and then there's still some context when we're using thalidomide. Well, what's the advantage of combining drugs together? Why don't I just get one drug? Well, we know that you get a better response, and we know that that response, at least in transplant patients, and we can correlate that to those not going to transplant, can improve things in the long term. I'm not going to bore you with some of the work that we do in our lab, but we're come to appreciate that in a lot of patients, it's actually really not one myeloma that you have. You actually probably have different, what we call clones, or different malignancies wrapped in one. And it's kind of like thinking of your lawn has several different weeds. And if it has several different weeds, you might need different kinds of weed killer to get rid of those weeds. And so it's important for us to be able to synergize the effect of drugs. So what makes me choose one strategy than another? And this is maybe if you've been napping, wake up for this one slide and go back to sleep. This is what's important, that risk status that we talked about, the fish status or the cytogenetics. But also if you really need something rapid. So we've learned that certain strategies like Bortezomib tend to work very quickly early on. So in our patient who came in this week with the kidney failure in the emergency department, we treated her with Bortezomib within 24 hours, and she had a very rapid response. Kidney function might affect because certain drugs are cleared or not cleared by the kidneys. Other diseases like having heart disease or diabetes and so on might influence. Someone mentioned about dexamethasone earlier. I might modify my dose of dexamethasone when I know someone has these things. The patient preference. You are important in this equation. And I know I can sound like I'm getting brownie points by the doctor saying that, but you know, I like to get my patient's opinion. I'm not the kind of doctor that says you'll take it and you'll like it, right? I mean, that doesn't work. Here, dear, take this pill. Trust me, I'm your doctor. You know, we don't really do that anymore. It's got to be a communication with you. Sometimes the own institution has certain protocols that might be of benefit. Cost is important, and I know that sometimes we don't like to talk about cost of drugs. And I really applaud the efforts of the IMF to address this issue because it is important. You know, you look at this and you say, wow, we've got these new regimens that are getting people into really deep responses. We call VGPR, or a 90% reduction of the tumor. Well, the reality is that can vary from $100,000 to $250,000 a year. That's a lot of money. And so we want to make sure that we're using it rationally and appropriately for every patient. All right, a few more slides and then I'm going to close so we can go to some questions. One of the key studies I would suggest that has perhaps influenced us the most in treating patients who aren't going to transplant is what's called the FIRST trial. I don't want to get into too much detail, but the bottom line here is it compared 3 strategies of giving just lenalidomide and dexamethasone as long as the patient was in remission until they relapsed, giving it for only 18 months, or giving the old school melphalan, prednisone, and thalidomide strategy. And the bottom line here is that the strategy of giving lenalidomide and dexamethasone continuously did significantly better than the other 2 arms, both in what we call progression-free survival and indeed ultimately in overall survival. And it taught us something. It taught us that when you take people off treatment, that's when their disease started to wake up. And so this is one of the moves now to not just treat people for a year or 18 months, but to treat people continuously. And lastly, we've also learned that as people get older and as our bodies become a little bit more frail, we have to modify the doses of these drugs. It's not like everybody's got to get 40 milligrams of dexamethasone and full dose lenalidomide and full dose bortezomib. This is a chart that I've given you for your reference. No one's going to memorize it, but a suggestion by a group, including Antonio Palumbo, who was mentioned today, that as we get older, we can dose modify each of these drugs as we care for patients. And part of that, for example, is using bortezomib subcutaneously to reduce the risk of neuropathy, which is something now we routinely do because it still is as effective as it was given IV, but it is much less toxic. For time's sake, I'll skip the carfilzomib. So take-home pearls, we don't like to mix lenalidomide with melphalan because of some of the challenges. We don't use melphalan in most patients up front. We don't want to interfere with people's so-called quality of life. You know that it's important to do that. Avoid high doses of steroids. And don't ask patients to drive too much, right? As I like to say, we like to try and find convenient regimens that provide that. We've tried to summarize much of what I've said today in what we call the M-SMART guidelines. I'm not trying to be a commercial for them, but if you'd like to go to msmart.org, you could find the details. And what we've done is we've just tried to give guidance to the community physicians as to how to care for patients. And there's a lot of detail here, but the short version is that when people have more standard risk or more standard myeloma, we tend to use less drugs together. When people have more aggressive myeloma, like the p53 deletion or the deletion 17p that Dr. Dury mentioned earlier, we tend to be a bit more aggressive in the way we treat them. I think of it as slow-growing myeloma. The tortoise doesn't need quite as much action or drugs to keep it still, or fast-growing myeloma that clearly needs more work. And thankfully, that's not the end of the story, that there's a lot more to come. And you're going to be hearing about this later today, so I'm not going to go through it in any detail. But we have a whole series of new drugs coming, of which we really think one in particular, the anti-CD38 molecules, what's called daratumumab, and another drug called SARS 650984, which just got a new name, isatuximab, will be drugs that, I know, who comes up with these names? I think one of my best friends has a daughter named Isa, so I think of Isa wearing a tuxedo. Isatuximab, right? Everybody? Isatuximab. There, you're in. And so there are some studies already that I'll leave that you have in your handout referring to adding some of these agents like daratumumab to the upfront setting, because the beauty of these agents is that they don't cause the kind of toxicities that many of our other drugs do in myeloma, like lowering blood counts or causing neuropathy or others. So I'm going to leave you with that and just give you some hope that we have a lot of drugs in our portfolio now, but many more that are coming, and we're already seeing that it's affecting the average survival of patients. This is our Mayo Clinic database. We're about to include the 2010 to 2015 number, and we're going to be drawing a curve that looks a little bit like this, which means that what we call median survival, or the average survival, is probably going to be landing around the 14-year mark. So I will stop there, and thank you very much for your attention.
Thank you so much, Dr. Mikhael, for this excellent presentation, and with the sprinkling of jokes, very good. You got very good applause. If I could ask Dr. Bessio to come up, and is Jean-Luc here?
Yes, he is.
All right. Jean-Luc, if you'd like to come up, also you can help us with the panel here. So please welcome, this is Professor Jean-Luc Harassot from France. So he's traveled all the way here from France.
Yes, just yesterday.
Yeah. And you'll be hearing from him after the break, but obviously a major expert in the area of transplant, so it's really a pleasure to welcome Jean-Luc. So questions?
Questions? Are you
Okay.
kidding me? Really?
Oh, it's all so clear now, they don't have any questions.
Yeah.
Okay, I got one over here. I paid him $5 earlier. I said, if nobody raises their hand, go for it.
Thank you very much, Doctor. I really appreciate your speech and your humor. I know that I'm outside the not transplant eligible patient base, but I had a question that perhaps you could give a little guide on. If you're trying to make the decision as a patient that you're on the borderline of either just doing the drug routine cocktail or going forward with the transplant, and you have the added factor of amyloidosis, would that likely, in your opinion, tip the balance to go forward with the more aggressive high-dose chemo transplant as opposed to just the drug routine and watch?
Tremendous question, and I'll answer it simply, I guess, is that, so for those who aren't familiar, amyloidosis is a disease that can be associated with myeloma, although generally speaking, we try and think of it as a unique disease unto itself. When I teach the residents, I draw two overlapping circles, and I say, this is myeloma, this is amyloid, they're two separate diseases, but there is an area of overlap. There are people who would, if you will, formally meet the criteria for both. One of the key things we've learned with amyloidosis, to some degree I said already for myeloma, you want to get that disease down right away, right? And that patient who came into the emergency department this week, we needed to get her light chains down fast because they were damaging her kidney. In a similar capacity, amyloidosis is a disease where the light chains that are made by the plasma cells in the bone marrow undergo a conformational change and deposit into tissues. And it's very critical to get that light chain level down very rapidly. So in answer to your question, if the drug therapy is not getting that level down very quickly and keeping it down, So the concept of minimal residual disease, or getting rid of every last vestige of amyloid, is very important. It's important in myeloma, but perhaps even more important in amyloid. Then that might tip me to go towards the transplant. We have pretty good evidence for transplant. That being said, we have some people who get treated with a bortezomib-based regimen and their light chains disappear in amyloid. And because sometimes patients with amyloid can have heart and kidney involvement that can make a transplant more difficult, we sometimes don't go to transplant right away. So it's kind of a paradoxical answer that I'm giving you, but yes, if someone doesn't have that big drop and they're healthy enough to go for transplant, we'll generally push it. On the other hand, if they get a good drop and maybe they're not as good a candidate as it were for transplant, we may delay it.
Maybe I just ask Jean-Luc to comment. So you would routinely consider high-dose melphalan in the presence of amyloid? If you could do it.
I fully agree with that Joe said. I think that amyloidosis is a good indication of a hydrotherapy plus autologous transplantation, but there are some risks, especially in patients who have several organ involvement and mostly heart involvement. So the results of autologous transplantation are good in amyloidosis, but the toxicity is higher than in multiple myeloma. So the decision should be taken carefully. And I agree that if the non-intensive treatment is very effective, then you probably don't know autologous transplantation. And if the result is not enough, you should consider autologous transplantation, but with a good evaluation of all organ involvement, especially heart involvement.
All right.
Okay, right back here, doctors.
The question is about cytogenetics. If somebody had a hyperdiploid trisomy with no evidence of 17p deletion or 414 translocation, how often they transform into high-risk cytogenetics, and what is the cause for that?
Okay, so
Sorry.
So if a patient has a trisomies, hyperdiploid, and at the beginning has no 414 or 17p, how frequently might they acquire some of those high risk later?
So it's a great question. It's hard to give you an exact number. As I mentioned, if we look at almost any database, including ours at Mayo, very often, but not uniformly, the people who live the longest are people who have had these trisomies or these hyperdiploidy or extra copies of chromosomes. Again, Brian mentioned we don't really know why, but it's just a phenomenon. It's also interesting that there's a small group of those patients who actually never get into complete remission and still live a very, very long time. It's like they've been returned to what we call an MGUS state. That being said, when I showed you that slide that we differentiate people based on their standard, intermediate, and high-risk status, just because someone starts in standard risk, it doesn't mean they'll always be there, which is one of the reasons why we repeat the FISH testing every time someone relapses, because unfortunately, this disease can evolve and people can acquire these things later. If I have a patient who's pure hyperdiploidy, the likelihood that with their relapses they're going to become high risk is low, but I can't quantify it. I'd probably say somewhere between 1 in 4 and 1 in 3 of those individuals will later become high risk. But the majority will still stay standard risk throughout their myeloma life. But it's a challenge to give exact numbers, because we're now just evolving in our understanding of it and being able to capture those. So I think the take-home message is, trisomies are associated with longer-term survival, but there is always the risk of unfortunately changing from a low risk to a high risk category.
Okay. So we have a question over there,
Question
number 3.
over here, please.
Okay. Go for it.
Yes, specific to the take-home pearls slide, there were 2 items on there that maybe the panel can elaborate on a little bit. The first one was don't mix lenalidomide with alkylators. Is that true for 4 treatment combinations, and where does that general theory come from? And number 4 was avoid high doses of steroids. What is considered a high dose of steroids?
dose?
What are you looking for to say that's too much for that patient?
Great
Okay.
question. So the
Okay.
first take-home pearl, I apologize I didn't spend as much time on it because with time's sake, I skipped over the slide that had shown there was a study that Dr. Palumbo led where they had melphalan, prednisone, and Revlimid together, the MPR study. And it was a 3-arm study where there was MP by itself, there was MPR, and then there was MPR followed by continuous R. And basically what we learned was there was no difference between MP and MPR, which was shocking because when we did MPT versus MP, MPT was better. When we did MPV with Velcade, it was better than MP. So why wouldn't MPR be better than MP? And it was because lenalidomide and melphalan have very much overlapping, we call toxicities. They both really drop blood counts. So you're you're unfortunately almost doubling up on doses, and you end up having to dose reduce so much so that you're giving ineffective doses of it. So the preference, very rarely now do we put melphalan and Revlimid together, is the bottom line. We just tend to give Revlimid continuously. So I was using it in that context. So not very often will you see those two drugs used together. The second take-home message, look, everyone in the world thinks that every myeloma doctor doesn't understand what high-dose dexamethasone means, right? Because we say 40 milligrams a week is low-dose dex, and they think you're cracked, right? That's 200 milligrams of prednisone, that's high dose. But compared to the high doses of giving 40 milligrams daily, 4 days in a row, 4 days on, 4 days off, some of you I'm sure experienced that, and now we've reduced it to the so-called low-dose 40. My general practice is, in someone over the age of 65, it's not like we cut it off or be ageist. Generally speaking, I won't give them more than 20 milligrams a week. And remember, the purpose of the dex is to boost the effect of something else. I rarely keep someone indefinitely on that amount. The most critical time for someone to be on dexamethasone is those first 2, 3, or maybe 4 months of treatment, and then we'll often drop it to 12 or to 8 or to 4 or even discontinue it with time. Because no one likes dex in the long term, nor the patient nor their spouse, right? Am I right or am I right? All of those who agree, sit down. See? Almost unanimous. So I think we want to be careful with how we define it. And it's really not defined by a number, it's defined on how someone reacts to it. There's some people, even at 20 milligrams, it's too much for them, and we have to dose reduce, and sometimes we can go to every other day prednisone. Am I on dex?
Are you on dex?
I'm high on Susie today, apparently.
Okay.
Oh, Suze. I do love
Love you, baby.
Dr. Mikhael, your number 2 take-home point, don't use melphalan in most. I think you explained that, first we're talking about what used to be the standard of care for non-transplant patients, and so that's relatively low-dose melphalan for a fairly long period of time. And you pointed out that can cause marrow damage that may make later treatment more difficult, if I understood it right. So how does that?
You should give the talk.
No.
It's brilliant.
Well, my question then is of course,
you are clear.
for those who are getting a transplant, the main treatment is high-dose melphalan, and so does that cause the same sort of problem with precluding later treatments that is damage to the marrow that might be long-lasting, and is that an argument against the transplant?
It's an excellent question, and I will let Dr. Harisu answer it. I'll start with the answer is that there is a bit of a difference between giving it continuously over a long period of time. That seems to sort of beat down the marrow more than that one single punch. But yes, there is some evidence that with time, as we know in the old days, it was harder to collect stem cells from patients after they had previously had a transplant, which is why we try and collect it up front. Now we have newer drugs and different ways to try and collect things a little bit more. But yes, there is some modulated risk of that, but that has to be balanced with the benefit of putting the disease down, right? So there's always some collateral damage, right? As I kill the weeds, there's some good grass that might never really grow back well. But it's all a question of balance. I don't know, Jean-Luc, if you have more to add to that.
So Jean-Luc, I
think that
you're going to talk about it in your talk, but you can maybe comment briefly now.
Very shortly, I think that you shouldn't compare long-term low-dose melphalan for 1 year, 2 years, 3 years, which I agree is toxic for the marrow and may induce higher risk of second malignancies, including myelodysplastic changes and even acute leukemia. So we all agree that long-term low-dose melphalan should be avoided. I have to say that in Europe, we still use limited duration of low-dose melphalan for elderly patients, and you quoted the MP-TAL or the MP-Velcade, which used melphalan for 18 months, so, but not more, certainly not more. And the second way of using melphalan is high-dose melphalan. Consider that it is a single shot, only one injection of melphalan. And there the risk of chronic marrow toxicity is very low. And I think that we still continue to believe that, and I will try to explain that in a moment, that high doses of melphalan are better than low-dose continuous melphalan, more active, less toxic.
Yeah, so we'll wait for that. But a key point is that after you give the high-dose melphalan, you give the stem cells back afterwards, so they're not getting exposed to the melphalan.
They are protected.
Right?
They are protected.
Anyway, it's a practical point.
One question we have, if we want to perform a second autologous
Yes.
transplantation when the patient relapses 3 or 4 years after the first, so then you're right, it's difficult to collect stem cells to perform a second autologous transplantation, which in a way shows that there is some form of neurotoxicity.
Right. Okay, other questions? Okay, maybe one or two more, and then we take a break, okay?
I have one here. Go ahead.
All right, go ahead.
Hello, thank you all. I appreciate that the assumption here is that short of age being a factor or other criterion such as health, that the transplant is the preferred method, particularly now. The question that my doctor has posed to me is that I'm relatively healthy, and the feeling is that there are so many new meds coming on board, and it will take another 10 years for them to really be tested out against, for example, transplant. But unless there was a good reason for transplant, he would say, why not go with what seems to be working? And I imagine your answer will be, but we don't know yet what the long-term is. Transplant is still showing up better. But can you give me an idea of what you imagine might be coming up? I mean, are we looking at perhaps less emphasis on transplant over the next 5 to 10 years? You know, if you could maybe address that difficult question from
You know, it's a great question, and it's one that we face every day. And there are people, even within our myeloma community, there are transplant dissenters, right? There are those who say, thou shalt not transplant, right? Because of the progress. And, you know, that's why I think I tried to mention that I do suspect that in the upper age end of where we're transplanting people now, in that sort of 65 to 75 time, where transplants are a little bit more difficult on the system, where, let's be blunt and honest, people aren't expecting to live to 110. Well, I guess if they follow
Well, of course,
Brian's
for me,
diet,
but-
you are. You know, where you know, if I say to a 75-year-old patient, you know, if your expected survival from your myeloma is 10 to 15 years, that's pretty good. That's a lot different than the 25-year-old I had in clinic this week, right? So we have to modulate that. So that's why I wonder in that group we might be using transplant a little bit less. But I think where we're going to go is to view transplant as another option. That just like I said, it's an individualized plan for everybody. There's some people in whom transplant might be ideal. I had a patient recently, they had a Bortezomib-based regimen, it barely moved their disease. They had then a lenalidomide-based regimen, barely moved their disease. We transplanted him, he went into complete remission. That person was clearly very sensitive to melphalan, and so that was the right thing to do for him. So we'd look at it as not always the big first card to play, but one of the cards to play. But I also think we have to be cautious that I'm not much of a boxer, but you know, you're the champ until someone knocks you out. And in many respects, in eligible patients, transplant is still the champ. I'm trying to boost my friend's talk here in a few minutes, right? You know, and it's not we get anything personally beneficial, but you know, it's a little bit of a difference giving one single shot of a drug as opposed to being on something else for 4 years that you take every day. So it's hard to match that pound for pound, right? So that's why I don't want to just dispense with transplants, but there may be some people that will do it less and will be using it as one modality, not necessarily as the central modality in the future. And in your situation, what I'm telling most of my patients is, until we really know if someone's eligible, I would at least collect their stem cells and freeze them, because that keeps the options open later.
So before we leave us, Bob, do you want to comment on what's the perspective here in the Los Angeles area, where there are some, there's a little diversity of thought?
There is.
Slight diversity.
There is a diversity. So there are those in the area that really feel like the risks and kind of the morbidity, the side effects from the transplant really isn't worth it. But I think it's hard, even with all these studies that we've done and ways of trying to identify good risk, bad risk patients with multiple myeloma. Ultimately we're trying to predict the future for people, and we can't fully do that. And for people that I know are even in the room, when they could look back, for them, the transplant was clearly their best treatment and allowed them to be in remission, off treatment, or on very easily tolerated treatment for a long period of time. And even the center, kind of in the area, has some of his longest term patients that I transplanted with him, let's say, and have done well for many, many, many years. So I think for some people, it can be the most effective treatment, and sometimes you find out a little late that maybe it should have been done. And there's always, you can make the argument, you know, for those people that, you know, the transplant could have been done. And I think the other thing for patients to understand is that people tolerate the transplant better than they did 10 years ago. It's not as terrible. It's easy for me to say, but it's not as terrible as it used to be. And people go home. I don't really get nervous about people dying from the treatment. It's just kind of how much diarrhea they'll have and how many weeks it'll take for them to get back to normal. So you just don't want to not use a weapon that for some people could have been their best weapon.
Okay, so good introduction for the topic coming up. I think that maybe we should leave it at that. I think that we are up to the coffee break. So thanks to Joe, thanks to the panel.